All right, guys. So I think most of you, when you know that I'm board certified internal medicine, actually did faculty at UC Irvine until '94, moved to the Central Coast, and have been practicing for about 20 years now. And so what my interest is when it comes to the cannabinoids, outside of cool slides like this, is really focusing on the treatments involved in cancer. That's been my real interest over especially the last 5 years. I see the world today, terrorism, loss of sense of self, and same thing goes with cancer treatments, is that we approach the war on drugs, the war on cancer, especially as Americans, we're warring on things and attacking and trying to kill them. And that's what we do in medicine. And we all know that time and a place to kill things. However, it's not the only approach. And what we want to do in integrative medicine is really, that's what integrative medicine is about. In Western medicine, we developed the best attack-kill medicine ever. The drugs and surgeries we have are profound. Okay. What we are lacking is a system that helps deal with something as complicated as cancer. Okay. I talk internationally now on the treatment of cancer. So subsequently speaking, when it came to the cannabinoids and being asked to do this talk, I'm quite interested in it, especially from the complexity of this system and how we're learning more and more about it. But it's so perfect because it fits into the same thing that the reason most anybody out there, if you've ever had any bias against marijuana, it's based on things that aren't true, which is how most people build their education system, is on things that aren't true. And so that's why I've learned through all those trainings you've talked about, is the more I know I don't know. And anybody who knows anything knows that, okay? Meaning I'm a student of this as much as you guys are. Now, because of my background, I certainly do know more about endocannabinoid systems and those things, but especially when it comes to any medicinal, and that's the key here, is dealing with medical cannabis, which is what it was called before the 1930s, when we started to label it and try to make it into something that it wasn't, okay? So if I use the term medical marijuana, it's a lot like me using the term vitamin D. Vitamin D is not a vital amine. It's not a vitamin. It's a steroid hormone. But I still call it vitamin D because everybody else does. Okay? Same thing goes with cannabis, is most people call it medical marijuana. So you'll see in the slides I slip in between those two, medical cannabis, medical marijuana. It's really medical cannabis. The term marijuana has solely been around to make you not like it. By our political system. So I love slides like this in terms of looking at all these wonderful little cannabis plants in utopia. So obviously, most of you know I like humor in medicine as well too. I've actually kept all my Far Side slides out of this. I'm sorry for all of you. I figured there was enough opportunity for levity within a cannabis talk that I didn't need any additional slides. So as we go on through this, my background, internal medicine, integrative medicine, I was realizing the other day, this is probably going to fall under too much information. I got my first colonoscopy on Friday. Yeah, you're welcome. Yeah, no, it wasn't. No. I won't discuss the prep in this setting. But, I did realize a little bit afterwards, that I've been a doctor for longer, more than 50% of my life. And so as you reach these milestones of, having tubes shoved up your bottom and over half of your life as a doctor, you must be getting old. It was the actor said he didn't want a Lifetime Achievement Award because it just means you're getting old. So I'm going to go over history of marijuana because I'm quite interested in it. And, I use the term marijuana once again because it's a colloquial term we all know. I really do want, at any time, if you guys want to ask questions, please do. Just raise your hand first and we'll do it in order and things. If you don't have questions, that's fine too, and want to save them for the end, that's great. But I want to go through the background of the history. If you're in the back, you can't see these. Hopefully you can see the slides that this matches. You can see? Cool. And if I can't hear me, just do the same thing, or make sounds. So Marijuana, a brief history. It really has been documented that hemp products have probably been used for about 10,000 years. In terms of their medicinal use, you can only go back to around 5,000 years ago in terms of really saying this is part of the Chinese pharmacopoeia. A part of this history, by the way, is when we know that currently Western medicine, America is still listing it as a class 1 scheduled drug, as no authentic medical uses. When we go through the entire history of medicine and we want to develop an understanding of this substance and start to ask questions. I wonder why I think this stuff is wrong. I wonder why there is, such a bias against it. Because it doesn't have a basis in medicine or science. It has been understood that the anointing oils used on everybody in the past, including Jesus Christ, had hemp as part of it. So that is a part of our religious history as well. Used in Egypt since 1200 BC, and I know these are old terms in terms of BC and ADs and things, but I like it anyhow. And we go through these basic things, and back into the mid-1500s where this was an understanding, and you could look at this right now as an understanding for today, medical hemp, as it was called at the time, or medical cannabis, as it was called at the time, should be probably a part of everybody's home first aid kit. Okay, cannabidiol oils or things for skin lesions. You could go on and on about the medical uses we could if we just decriminalize it and make it something we can understand and utilize better. I will also talk about the downsides of marijuana too, because I think a disservice to the world has been done by some of the websites. Cures cancer, like it cures all cancer. Absolutely no one's ever died from the use or ever had a problem. That's a disservice. Anything that has a psychoactive effect can have negative effects, including cannabis, okay? So we want to have an understanding of it and where it fits into the safety profile of things and who's at most risk of the complications from medical cannabis. Jamestown settlers brought it to here. Hemp was a big export product from our country in the past. So again, this is a proud part of American history. The Anatomy of Melancholy in 1621, cannabis is a treatment for depression. We'll talk about the changing scope of THC as a component of marijuana, okay, and how it's changed the plant's psychoactive effects. How some of the effects in the past are not going to be the same as now because of the high concentrations of THC and how that's changed the potency, the power, and the side effect profile of cannabis. So we know the Queen of England probably used it, goes into that U.S. Pharmacopoeia in 1850. Okay, so this is part of the U.S. Pharmacopoeia in 1850, an understand, recognize, medicinal herb. Okay. Now, as you know, in the early 1900s was the start of the kind of a prohibitionist movement, again, against doing quote-unquote immoral things. Prohibition itself was from 1920 to 1933. So in this area is when you start to get people who are trying to outlaw, and you see as you get to 1930 a shift in the attention towards the demonization of psychoactive substances in our society. And it included alcohol, of course. Prohibition was such a success. That was a little... Yeah. So this was reefer madness. And I want to emphasize, when we started to criminalize it, there was a whole swing of this movie called Reefer Madness came out. Women cry for it, men die for it. The black side of swing, one of the key components of passing this law and to make it criminalized in society was basically that black jazz musicians were corrupting American white youth with this drug, okay, which of course was not true. But you'll find in today's politics, actually it's that kind of things that get bills passed, okay? And so these were the kinds of things, the sex craze of this, which is really quite interesting. In monastic traditions, hemp was actually used to try to suppress sexual desire. Okay, that was one of its effects. Where, of course, this turned you into a sex crazed maniac. So these were all the marketing tools that were coming out at the time to demonize marijuana. It's just an interesting part of our culture. And you might think, what does this have to do with? This has everything to do with the medical talk, because pretty much most people are still working with 1930s mentalities in terms of when it comes to this, because they learned to this. And when I talked to her earlier about holding on loosely to knowledge, knowing that you know nothing, People want to cling to these things as belief systems because they've been believing in them so long, it's tough for them to let them go, which is true for most belief systems. So the League of Nations becomes part of this. This is in the middle of Prohibition era. Okay. However, still we're seeing Eli Lilly selling cannabis extracts medicinally at the time. The Hearst became a big component of starting to announce marijuana. It's right in this time that using the Spanish surname in some of the anti-Mexican movement to switch the name towards marijuana from cannabis, which was what it was being called at the time by the medical profession, who are the primary ones, AMA, 1937, opposing the Marijuana Tax Act, supporting research on medical cannabis. Okay? And of course, this is one of the few times you'll see the AMA beside something where they actually said, no, we really need to study this stuff, but it got passed against anyways because of the sweeping, again, it was a political decision, not a medical decision. Based upon things like this, by the way. And again, from 1850 to 1942, part of the U.S. Pharmacopoeia, medical cannabis. Taken away because they were going to reestablish and set it as a Class 1 drug. 1938 report basically showing that all the catastrophic effects. So there was always history, even going back to the 1930s, that the claims being made against it were sensationalized and inaccurate by medical studies, but still it went on to become something that was damnified. And this is so important because we've lost the ability to research this. Why I don't prescribe marijuana more than I do is because I don't know how to. I can't get adequate training, and I have to figure out what the best way of doing these things. And all these factors made this so difficult. Okay. By the way, it's starting about here in 1964. We first, 9-delta tetrahydrocannabinol, THC, which I'll call it just THC from here on out, it was first identified. So it's just in this time in the 1960s that we're identifying THC. These are on your handout, so I'm not going to go through all of these things. But here it is in 1980. Okay, this is another key moment in American medical history. So, and it is pretty fascinating that there are head-to-head trials using they're basically called randomized crossover trials, looking at Marinol, looking at smoked marijuana. What was best in dealing with chemotherapy-induced nausea and vomiting? The smoked marijuana did better, by the way, but marijuana still still stayed a Class 1 drug. Okay, while Marinol, which has a pharmaceutical lobby, became the accepted standard of this kind of medicine. Isn't that fascinating? Just think about when I say this. Most of you guys have heard me talk, and it's so important to understand we don't want to be upset about these things. It's just we want to see the isness of things. There are some isness of things. I'll mention when my things are just the way they are, like this is when 1980 marijuana coming along. But this is there is a lobby to support unique pharmaceuticals. There isn't a lobby that's powerful to support these other things. And it's part of how we're making decisions in our society today, not just 1980, about what is right and wrong to be used in medicine. Yes?
So it says that Marinol is synthetic. So what exactly is that? And how does that correlate to this thing spice, which is also a fake?
Well, there's many synthetic, and we'll get to the question relates in terms of you can, like many things, you can synthetically create levothyroxine, which is thyroid hormone. You can synthetically create delta 9 tetrahydrocannabinol. You can synthesize 9-THC in the lab. So this is just a lab version, synthetic version of a natural substance. Okay, so it's THC, but you can synthesize it. I think it has a few different methyl groups different, so it can become a patentable drug. It had the same effect as THC, though. Okay, and then we'll get into the whole market for looking at synthetic cannabinoids, because the real issue right now in terms of why it's still illegal is because there's so many, because it has this is the funny part, no recognized medical benefits. There are so many drugs being made right now based on the endocannabinoid system, on phytocannabinoids, despite the lack of having any medical use, which is why it's a Class 1 substance, which you notice the hypocrisy there. There's absolutely no sense being made of any of this. So Marinol is out there. Marinol does have some effects on chemotherapy-induced nausea and vomiting. I really want to make sure you hear that. It's not a useless drug. I've used it in people who did not want to use marijuana for their personal reasons and political reasons, for glaucoma and other things. It's just very expensive, variable coverage by their insurance, but it does have some effects. As we go on, the whole shift now is towards all the other cannabinoids, not just THC. THC is the primary psychoactive cannabinoid. There's a gazillion others. When I say gazillion, 60, 70, 80, 100, depending on who you read. A lot of other cannabinoids. Free for treatment of nausea. Judges are trying to get marijuana moved to a Schedule II, some therapeutic use, but potential for addiction as compared to no therapeutic use and very addictive like Schedule I. Okay? But of course, the DEA overrules this and overrules the American College of Physicians. They are overruling everything. All the medical societies are saying we need to change this, and it still gets overruled for political reasons. Back in 1991, 53% of oncologists, man, that's a relatively conservative group, thinks that this should be available to their patients. 1996, go California. 1997, New England Journal of Medicine calling for marijuana to be Schedule II drug. So all of our big medical societies, I mean, this is 17 years ago and it still hasn't happened, right? So all the medical advocacy boards are trying to get this away from being labeled a Schedule I drug, which is so limited our research, by the way. Okay. The main reason this is of concern to me is because getting research on cannabis extracts is next to impossible. The group at UCSF, Dr. Abrams, he has a group that's working on some of these extracts now because he was able to get separate funding and get some cannabis sent to him from the National Cancer Institute, from NIH, excuse me. And so we're getting some research out there, but very, very little on the whole plant extract, which is the key component as we get to the actual medicine side of these things. This is an interesting, when they're looking at the states that are legalizing marijuana, you're getting a dramatic reduction in DUIs and drunk and all kinds of, fatalities, et cetera. So, I don't expect those kinds of data to change things too much. You never know. The main reason, let's face it, most of us had drinking and you feel like going out and jumping off bridges. That was me. If you smoke marijuana, you feel like staying at home and we're going, hey, dude. And so I think it even makes scientific sense if you look at the effects of within yourself of how marijuana affects you versus alcohol. And this does go into this whole safety issue that we're talking about. When we get into how many people are killed in the world from alcohol or from nicotine or from all these other things, it furthermore just doesn't make any sense to put marijuana where it's been placed in our society. But it's amazing how persistent it's been, despite all of our medical societies and judges and everybody trying to call for a different approach to the substance. Currently, 23 states have legalized it for medical marijuana. I think it's, 2 for just marijuana in general. But on that order, we're making a shift. Hopefully it'll come around. And then the real fun will begin in terms of looking at the medical uses of marijuana. I'll talk about recreational marijuana because be quite clear, to say that there's a complete line between the two, come on, who are we fooling here, okay? With most substances, the 12,000 people a year who die from narcotic overdoses, okay, that's because there's a crossover between what is therapeutic and what is actually being used recreationally. It's true for everything, okay? Thomas Jefferson. So this quote is in there, but I do believe that when we look at the state of condition right now, this living under tyranny, when we see how we are being controlled in a certain way, what's available to us, what the war on drugs actually means, we'll see that we're far away from what the Jeffersons and the Lincolns and everybody else that founded, well, Lincoln wasn't a founding father, but the Washingtons, etc., in terms of what they thought of what we should have access to, in terms of not having the federal government determine. And it's a really interesting thing when you look at some people are for the self-determination, people determining their own rights, unless they don't believe in something. And so we have to look at how that is. It's very fascinating. Historical conclusion. So cannabis has unquestioned been used for about at least 5,000 years throughout transculturally from India to Central Asia, all across South America, and it's still being used there. Much better research is being done in other countries because they can do it. The policy of criminal stems from fear, racism, and ignorance. That's basically anybody who still has a stance against marijuana is working from at least one of those three things. And we need to educate people, that's why we're doing this, to get them past at least the ignorance, okay? Fear and racism are still out there. I think we all see that, okay? But that's the primary. When I talk about this, there's two primary things keeping marijuana illegal, which is keeping us as the number one in population enslavement, meaning the number one country in incarcerating their society. So the anti-drug movement is about a system of keeping a certain group of people suppressed and making money out of them, a form of enslavement, and the capitalizing on drug patents that are going to come from this. Okay, and that's it. That's why it is. You can sit with it and be with it. It's just, that's the isness of what's going on right now. And so hopefully we can get people who make better decisions than that. And the war on drugs really has been very, very clear, okay, a war on the general public, not about a war on drugs. And the war on drugs, like the war on cancer, neither can even possibly work because they're working against the very nature of human beings. Is that understandable? I know that's going to be quote unquote controversial to you, but it is, and it's just kind of what's happening right now. Now, getting into the meat of the talk. So that history of medical marijuana, completely lucid for all of you. Quiet crowd. We need to get the wine going. My talks always go better with the wine. We used to do our talks at the a French restaurant. It really makes it go better.
Hey, well, I got something to say then.
Yes.
It's a recommendation, not a prescription. Just so you know.
Yes.
Doctors give recommendations, you said prescription.
Well, we can't.
For medical marijuana, then our pharmacies would have to, that would make it kind of like rehab. They pay for it. That's why alcoholism is a disease. And so it's the pharmacies not wanting to recognize our medicine as a real medicine and or a real disease curing the property. That's why that's the recommendation.
Correct. And what he's saying is true, is that, and the very basis of the problem right now is doctors can't prescribe it. They don't have the education or the ability to prescribe it. They can make a recommendation. They actually are pretty much, it's like about as useful having a doctor prescribe. Most doctors prescribe you diets. They don't know anything about nutrition. You don't want them prescribing nutrition to you. Okay? It's the same basic concept. Since they don't know this area, do we really want them prescribing this? No. Can they do it legally? No. Actually, when I write my as everybody knows, the basic form that we use so that people can have access and get their marijuana, they get most of their education through the people who deliver their marijuana, etc., which is a sad state of affairs. Okay? The doctors do need to be better, especially me. I want to be clear about that. In terms of how to do this outside of saying, gosh, and then we'll talk about my conclusions at the end. But thank you, it's a very good point, which is a doctor can at best make a recommendation that the patient can get medical marijuana. It's not actually a prescription. Even when I write down to my patients, I'm on the legal cusp as I say sativa versus indica, et cetera, I certainly can't go as far as saying I want you to inhale X amount of milligrams of cannabidiol. That would be actually against what I can do. Okay? Even though that's exactly what I should be doing, that's why our government is currently working against you and your physician, the war on you. So that's exactly my case. Now, the pharmacological actions of the non-psychotropic cannabinoids. This is the stuff that I like. And when I say I like the other stuff, I like understanding where we come from. I'm a big history buff in terms of the development of most medical systems from Ayurvedic and otherwise and Chinese traditional medicines, etc., in terms of where they use these things, okay? But I want to point out that CBD, which is cannabidiol, okay, different breakdowns, cannabichromine and geranol. These are THC derivatives. Most of the research right now, in terms of, this is very important, on CBD as an antipsychotic, as a neuroprotective, vasorelaxant, anti-ischemic, anti-proliferative, anti-emetic. And again, is have many profound anti-inflammatory influences. There's some trials that look at that milligram for milligram, cannabidiol, CBD, okay, is possible. It's about 20 times more potent than aspirin as an anti-inflammatory, twice as potent as hydrocortisone, okay, a very powerful anti-inflammatory. Now, this is where we have to get into the medical mindset. When we're talking about someone going out and getting a high THC marijuana, that's a pleasurable thing that people want to do sometimes. I'm not even going to talk about that for the most part, because that's more the recreational side of these things, which, again, I'm not even stating one thing about. Yes?
I disagree with that.
Okay, state.
I think the reason
This is
we
great.
use CBDs for children is because they can't handle psychoactivity. The research I've done, and I'm a cancer patient on RSO oil, high THC turns off the cancer switch. In 3 months, I have no detectable cancer. I did do God and chemo, but I believe the THC, my own personal, I've been involved with this since inception. I believe is a key component. I believe that the media and everybody's promoting these CBDs, because you can get that from industrial hemp. It's available right now, online, legally.
Correct.
But we're not pushing it.
Correct.
But we're pushing that for marijuana, but we're saying that THC is not important.
Right.
I really am offended by that message.
Okay, so what the gentleman is talking about is what I would like to point out, number one, because of his passion, he's not even been able to hear what I say. So let's use you as example right now, if you don't mind, okay? Because I didn't say that. What you did is mishear something because of an attachment to something. And I really actually want you to lose that as a learning thing. When we're attached to things, we can't even hear what someone's saying. So let's go into when I talk about just using totally high THC with no CBD, no other things, that's recreational marijuana. When we talk about using THC along with other cannabinoids, we're getting into the medical marijuana or medical cannabis. So instead of hearing that, it was like, oh my gosh, he's against THC, which I'm not. What I'm telling you is the psychoactive component, THC, okay, has many roles in terms of this, and we'll get into other roles of THC, but THC unbalanced, which is the primary reason we've gotten to so much damage in the whole community, is high THCs relative to other forms of cannabinoids have imbalanced the medical cannabis because of the recreational side effect part of it. Okay. So the rest of the cannabinoids, and this is just putting it in the same way, this last chart, the beauty of this is it's looking at the different membrane receptors, 5-HT1As, and different mechanisms, so especially for the nurses in the audience and the doctors in the audience, okay, you can actually look at how these things work, which receptor sites these things are working through, okay, so there's many sites where all these things are becoming, and if you notice all these effects, they're just becoming clarified. When we talk about the entourage effects, which is when you use medical cannabis, it's not just the THC or the CBD or the rest of the things, it's the entourage effect of the and the rest of the triterpenes and the other 500 constituents, the whole plant, which is important, not just THC. Now, the endocannabinoid system. So, when we get to the endocannabinoid system, this is a beautiful thing. Most of us know it started off with morphine and the opiates. We didn't know exactly how they worked, and then we found these substances within our own brain called endorphins. They were called that because it meant endogenous morphine, right? So we found out how the opiates worked, and we found the receptor sites. The same thing happened decades later. I think it was the 50s that the opiates were found. Don't quote me on that, but it's somewhere in there. And we'll talk about these. It was in the 80s that we actually were finding. 88 was the first time we found a receptor. 90 was it was highly classified. So it was 1990 we found the endocannabinoid system. So the beauty of this is you out there have an endocannabinoid system. Now, most people here, I think, probably are aware of that, correct? How many, and please answer, how many people are aware that they have an endocannabinoid system? So this is news for most of you? Wow, okay. Okay, so this means you're walking pot makers. It really doesn't mean that, by the way, but it sounds funny. You have, and this is true for most of medicine, we will have and people like this key versus lock things. I don't like calling receptors locks per se, but is that if there's a key coming into your body, it's got to find a lock, it's got a place to land, okay? So when you get the psychoactive components of different things, there's at least 3 primary receptor sites, and there's many more. I already pointed out to one of them for your own cannabinoids. The cannabinoids that you make, anandamide, which is named after Bliss, Ananda, the Satan Ayurveda, by the way, anandamide and 2-AG are the primary recognized endocannabinoids, a family of locally acting, so eicosanoids. Eicosanoids are like prostaglandins and leukotrienes that you've probably heard about. Locally acting, basically hormones, if you will. Hormones can be long-distance acting. These are autocrine, meaning acting on the same cell, or paracrine on the cells around them. So eicosanoids, okay, are hormones that work locally. Okay? They come from the release from the cell membrane on demand. This is very important. Your body makes these signals, these cannabis molecules. They are, for instance, part of the runner's high, just like endorphins. So the endocannabinoids are activated by many things. The fatty acids are released from the cell membrane under stresses, hormonal signals, so many other things, and you make these things on demand. I didn't even get into how they're broken down in the body and things because that gets a little too technical for most people. Because this is so crystal clear. I didn't, because I knew this was going to just, whoo, but this is so easy, Gary. Why didn't you give me the whole thing, the fatty acid hydroxylases? So there are actually several more identified endogenous cannabinoids, endocannabinoids, that have a myriad of actions. This is the cool part, people, is that there's so many effects, receptor sites throughout the body, and we're just finally getting around to researching it. My main issue with the criminalization of marijuana is we can't research something so important, so complicated as your own body. And that's what's happened because this research, of course you can do this, there's just not funding, etc., because of the bias against it. The CB1 receptor found primarily in the central nervous system, PNS is peripheral nervous system. Okay? CB1 receptors primarily tell us a lot about the effects, the psychoactive effects, especially of THC. CB2 primarily affects the immune system effects of the different cannabinoids. This transient receptor potent potential cation channel subfamily V receptor member 1, or the capsaicin receptor, this explains some of the pain modulation. The marijuana and marijuana itself, and the endocannabinoids work on a set of receptors that were thought to be mainly the capsaicin receptors involved in pain perception. Okay, so this is another mechanism of action. And the full role of the endocannabinoid system is yet to be determined, but there's a role in anxiety, depression, pain perception, learning, appetite, cell cycle regulation, immunomodulation, muscle spasticity, and much more. So we're expanding this way beyond just psychoactive effects. Okay? And so this is your system. When we get to phytocannabinoids and synthetic cannabinoids, remember, this is the system you're working with. Lots of the theories in terms of why there are some negative effects are about the downregulation, especially in the developing up till about 18, up till probably even 25, the developing brain, some of the negative effects of the psychoactive components to the cannabinoids. And this is another look, I'm a visual person as well too. I know when I'm writing these things down, they seem to make sense to me. Sometimes the locking key thing, this is obviously why I brought this up. These are the classic THC, cannabidiol, okay, and cannabinol. There are many, many more, okay. They work as neurotransmitter regulators, so they're basically a neuromodulator. What we're finding is there's really, there's almost so little difference between a hormone, an interleukin, a neurotransmitter, because they have so many different effects within our body. We talk about serotonin. What most people know, something like 60% of the serotonin, up to 80%, according to some people, made in the GI tract. The roles of serotonin go way beyond depression and anxiety. They have other roles in the body, including inflammation regulation. So when we look at these things, these are just basically the CB1 receptors primarily, but not entirely, in the central nervous system and the peripheral nervous system. Okay? The CB2 receptors, and these are primary receptor sites. Remember, this is especially important when we start talking about some of the drugs that were developed. They're going to be CB1 agonists and CB1 antagonists, and what they were hoping to accomplish with these different medicines. So this is your endocannabinoid system. So primarily when you talk about medical marijuana, medical cannabis, okay, what you're talking about isn't the endocannabinoid system. This is your own body, right? Okay, this is where it's its playground, okay, more or less. I mean, that's where these things interact with, of course. So it's important to understand this. Unfortunately, this work, like I said, they didn't even identify these receptors. Many doctors don't have any education on this. All these different receptor sites and things, unless you really look for this stuff too, because it's not part of most mainstream medical literature. Does that make sense? Cannabis and phytocannabinoids. So what we're talking about now and is really getting towards our prescriptions of what we're using. There's, again, and we'll talk, there's a picture of a few of the plants and things like that. There's even the difference is that cannabis sativa and cannabis sativa indica, you know, again, I think there's some debate even within the herbology world. So basically, those are the primary ones we're talking about, and I'll show you some pictures, okay? This is my actual main concern, is that as we go from the main issue, especially from a production standpoint, was been for the standpoint of recreational use, is increasing THC in marijuana. Yes?
Hydrating these plants to make it more THC dominant, that's
Correct.
also hydrating them to make it more CBD dominant.
Correct. Well, so the question goes like this, okay? The primary market right now, if you are growing marijuana, is to have more THC-rich marijuana, and because it's your biggest market. That's what you're trying to sell. You're growing this stuff, you want to sell it. I mean, that's pure business as far as that goes. Has there, in the recent years, been, and we'll talk about that, people trying to work on more high cannabidiol things? And the answer is yes. And the gentleman here was pointed out that you can get that in generic hemp. There's CBD oils everywhere. I'm not disagreeing with that at all. Those things are available. The question comes back down to, though, is are these oils as effective as whole plant extracts? Okay, and by the way, the answer at the end of that is going to be we don't know, okay, because it has not been tested. But the point here is, are there now some push as the medical marijuana movement kicks in to have higher CBD fractions and start experimenting with those and seeing what kind of effects for different conditions. Do you need a more higher, and especially when it comes to cancer, by the way, higher THC fractions might be especially important for lung cancer, whereas higher CBD might play a bigger role in breast cancer. Okay, now, and do we know that entirely? Well, if you look at basic science studies, CBD for breast cancer seems to be a better cannabinoid, whereas THC might be better for lung cancer, et cetera, et cetera. We need more research, okay? It's probably going to be a balance of them, and more than that, the other cannabinoids, et cetera, okay? It's much more complicated than the current debate, THC versus CBD. Yes?
What happens when they are growing the THC higher to the rest of the other properties? Are they...
You're diminishing the content of the other cannabinoids. So you're hybridizing towards higher and higher THC. The question goes into what happens when we're doing this, and it's not like I'm trying to make it wrong. Whenever you extract or get something with a higher concentration of one thing, it almost always has a lower concentration of something else. And as we get into this component of things, okay, you know, extracting the intelligence while leaving the wisdom behind, we got too focused on one component of this. Okay, so, and this goes into, so we're concentrating to this. As you know, if you go to most of the online, I'm going to recommend one online pharmacy just as a reference to you. You can get 20% THC, 24%. It goes on and on. I mean, they're much more potent these days. And I'm not saying those things are wrong. I'm just saying when I'm using it medically, I don't need that high of a concentration most of the times. When you get into the other phytocannabinoids, what role they play is still to be determined. There's not as much research going on them. The entourage effect. The entourage effect is understood throughout, and specifically applied in this case, is there is a synergistic effect of CBD plus THC plus CBN, et cetera, and all the other cannabinoids. And why is that important? When we just isolate and just want one product, we usually, and this is true throughout all the drug world, we extract the intelligence, leaving the wisdom behind. Most of the times, okay, if you focus on one thing, you are pharmaceuticalizing the herbal world. Anybody who's practiced herbal medicine will tell you the whole plant is what has been prescribed. It has many balancing effects. And even though there's a primary component, okay, if you take the monocolin A out of red yeast rice extract, you get Mevacor, a drug for statin drug that's become wildly popular. However, there's so many other things present within red yeast rice extract that make it work better for the long term. Okay? The same thing will almost certainly be true when you take just the THC away or just the CBD away. Okay? Same concept. Okay? From a extract, you are doing exactly what we've been doing with most herbal medicine. We're extracting the intelligence and leaving the wisdom behind. All right. So we're going to go through and get into we've tried to go through the history of medical marijuana or medical cannabis, and we're trying to move now into how do we get to the therapeutic applications of things. What has been shown to be true for either the cannabinoids, phytocannabinoids. And again, I gave you some pictures of these things, the sativa plants, the indicas. We'll talk about some of the differences. This is used as a hybrid, helping hybridize with other plants in terms of changing the spectrum of cannabinoids within the sativa plant. This is a basic look at the male and female plant, so you have an idea of what we're talking about, since, again, whether it's endocannabinoid systems or the plants themselves. Basic difference of how we view sativas versus indicas and their therapeutic effects within the person. Okay. Now, it is really quite interesting, by the way. It's a good time to bring up. They've shown that people who have a history of using marijuana, that the things they like about marijuana are the things that patients call side effects if they never used it as a kid. Okay, so it is fascinating that at one point when there was an article that I was reading. Gosh, this is like from 20 years ago, how basically it's only good medicine for potheads was what the doctor concluded. And there's actually some degree of truth in that, because they get the former quote-unquote potheads actually the ones who get the fewest side effects, because they look at the quote-unquote side effects as, well, effects that I was looking for, thank you very much. Whereas the people who don't like that, they call it side effects. It's quite interesting, of course, because in the medical world, we always talk about side effects of a medicine, and there's no real such thing. They're just effects. The ones you want, you call effects. The one you don't want, you call side effects. So, it's like in the herbal world. What's really a weed? I was at a talk a couple of weeks ago with this guy who loves dandelions like they're the end-all, be-all of the world, and I yanked those suckers out of my yard and nobody's business. So, what's a weed? What's the side effect? So it's kind of interesting. But this is the basic difference if a doctor is talking about how people use sativas versus how people use the indicas in the plant world. And what was pointed out earlier in terms of a physician recommendation for medical marijuana, basically, if they think you have a condition, which clearly can be next to anything if we look at all the effects of medical marijuana, then it's down to you in terms of how your body responds. Do you like the sativas? Do you like indicas? Do you like hybrids? It's an experiential process. Most of you know how much I am about experiential medicine. If you went online and read the side effects of playing tennis, oh my God, I can die, okay? Well, there goes tennis, okay? Swimming, well, gosh, eaten by sharks, no more swimming. And people are going online to experience life now and not diving into it, okay? Now, there's a point to saying, gosh, well, I don't like swimming. Well, then don't try it and try something else. So personal preferences, but people have this thing where if they've had a side effect with something, they want the whole world to have that side effect and make it bad for everybody, okay? And that's a problem. If you don't like tennis, don't play it, okay? And if you don't like a certain type of marijuana, probably not the right one for you. Just really that simple. But be experiential with anything in your life, whether it's tennis or sativas or indicas, okay? And this is basically looking how, when you go to some of the websites and looking at what are you buying? And if you're buying something that's like this, and this is different types of marijuana extracts, we look at this is what you can find in there. These are the different, what can be found within this, and this is what a bud would look like. And I just figured it's important for you to look at in terms of people who have no exposure, because especially many of my patients are patients who have cancer, and they came in with a background, well, I'm not going to do that. I'll do anything in the world. I'll take any narcotic in the world. I'll take anything else in the world because it's legal, but not that marijuana thing. And we have to bring them around a little bit and get some comfort with what this marijuana thing is. It really is a fascinating hypnosis of social conditioning, it's called, and where people have this predisposition, I'll do anything but that marijuana thing, and when we look at all the toxicities, and we're just trying to demystify, well, this is what it is, and this is some of the components, and depending on what you're looking for, you might want this breakdown or other breakdowns. Synthetic cannabinoids. So if you remember, there's 3 basic forms of cannabinoids that we talk about. There's the endocannabinoid system, which is you, and your body making cannabis-type molecules and binding to it with specific receptors, okay? And then there's phytocannabinoids, basically the cannabis extracts, okay, and hemp. And the synthetic cannabinoids, which is the focus of most of mainstream medicine these days. Identify a receptor or identify a compound and try to come up with a pharmaceutical equivalent so that we can make a drug out of it, okay? And that's, to me, part of the problem, and part of the reason why we're keeping whole plant extracts away, because of the things we've already talked about, and because there is big money to be made in these things. Now, right now, 1980, Marinol became available. This is the only other one available in America, which is Sesamet, which is both approved for the nausea and vomiting of chemotherapy. They have similar efficacy. That's what they are indicated for. Not that they can't be used for other things, but that's their current indications. And again, people respond differently to these. I've prescribed both of them, and they can be useful in that setting. Okay, it's not my primary way. It's basically if people say, I'm not going to do that marijuana thing, but I will do this extract, this component thing, and that's okay, because you have to work within people's belief systems. Okay, Sativex is a very fascinating cannabis-based pharmaceutical delivered by a mouth spray. It has a THC to CBD ratio of 1:1. Okay, it's not yet approved in the U.S. I think it's in 15 countries. It has a ratio per spray of 2.7 milligrams THC, 2.5 milligrams of CBD. It's a cannabis-based, so there's many other terpenes and other phytosterols, etc., present within the base in a variable ratios. And you can use 12 sprays. You can keep going higher than that, but what they recommend is titrating up to see the effect. Primarily, once again, this is being used worldwide, especially for neuropathic pain syndromes, okay? So MS and other forms of demyelinating doctor speak, painful nerve conditions, okay? And it has some success. It has double-blind trials, which shows the things. The problem with double-blind trialing, do you have a question?
Yeah, what about the peripheral neuropathy from chemotherapy?
It's useful for that as well, the peripheral neuropathy with chemotherapy. It's definitely successful in treating that as well. Thank you. And so peripheral neuropathies from all components can be used. And one of the key things is most of the drugs we use for peripheral neuropathies have nothing to do, they're anti-seizure medicines or opiates or other things. So peripheral neuropathy is a condition of pain associated with nerve dysfunction. Okay, many causes for it, from diabetes to other forms, but chemotherapy as well. And it doesn't have good treatment, and this is a much safer version of treatment than using opiates and other things. Okay, so there is role for that. The first drug that came out that was approved in Europe only, okay, rimonabant, never been used, was approved and withdrawn in Europe, okay, as a CB1 receptor antagonist that basically most people have heard of the munchies, right? Okay, so they thought, gosh, if we could get a good appetite suppressant, we'll block this CB1 thing in the brain, and that will help us with decreasing appetite. By the way, it does decrease appetite. Unfortunately, it led to a higher rate of depression and suicide. Bummer, okay? Now, this goes into the complexity. See, we're very reductionistic in Western medicine. We want to be more inductionistic. We're trying to find one thing that does one thing, and that's what pharmaceuticals are good at. This is extreme. This is why I like this stuff. It's an extremely complicated system that people don't have a clear idea of, especially if we're looking at CBD to THC ratios. There's competing effects. CBD given before THC has one effect. CBD given with THC has another effect. It's when I say awesome, it's awesomely complicated, okay? But it's still yet to be worked out because we need more research in this area. But what we're clear about is doing CB1 receptor antagonists can have, of course, psychoactive effects. This goes into the point, can we use, because we'll get into a little bit in terms of recreational, can we use, and it's very important, medical marijuana for treating some of the conditions we say that it causes? And the answer is yes, depending on the forms. Okay? But can it help with anxiety? Yes. There's very good trials showing it can be very helpful with anxiety. People have certain genetic polymorphisms, and this goes into some of the things we'll be doing in the future, might get more anxiety with it, however. Okay? Will we be able to do pharmacogenomic testing, looking at your gene profile and saying, okay, this is a good reason not to be on this form of cannabinoid because you'll get some of the toxic side effects. And that stuff is coming down the road too. Okay? This goes into the metabolism of cannabinoids. But anyways, this is a little bit of the synthetic cannabinoids, because when we're talking about medical marijuana, most doctors, MD-type doctors, are talking about these synthetics and what's coming down the drug, the pharmacological pathway, and working on specific either antagonists or agonists of a receptor site or specific congeners, things that look like THC or other forms. Okay, and there's more out there, of course, but I'm just pointing out what's available right now, what's been used. There's many more that might get drug approval, and you never know. They might have some benefit if you find a specific CB2 receptor agonist that has an immunomodulatory effect similar with low toxicity. Maybe there is value in this research. I want to emphasize that. The concern, once again, is you're focusing on one small component of a very complex system that usually, almost always, is flawed approach. This is the sativa spray. It's just a sublingual spray. I have a slide in the future talking about oral versus inhaled and absorption in terms of how to get the best effects. Yes?
So again, with something like that, since you can't prescribe it, you know?
Sativex is just in Europe, not here.
Oh, okay. So how would you,
Which is second.
use that for like a peripheral neuropathy? How would you suggest it use?
Well, I can't use Sativex in this country. Okay, so once again, I was letting you know what's available in the world as well. Okay, and just a second, I promise. And so on that order, we would be recommending, hopefully, using a recommendation for medical cannabis and experientially trying different things to see what worked for you. Yes.
In my research on Sativex, they use a 1-to-1 cannabis THC ratio to get rid of the psycho effects of cannabis.
The right way is just.
Activity of the cannabis, so you don't feel any.
Right. What they're talking about is the reason most medical cannabinoid mixtures are in a 1-to-1 ratio is you can, and used of course concurrently, is you can counteract the psychoactive effects of THC with CBD. Okay, and for people who don't want that effect, that's a good thing. You know, if you do want that effect, then you know you're a little bit bummed. This goes all into how you look at it, you know, and so. The reason to talk about recreational cannabis is because, like I said, if you look at prescription opioids and how they're used in the world, and prescription, and again, I agree with well, I'm still going to keep calling it prescription cannabis, but just when we make a recommendation for you to use cannabis, it has the potential for abuse. It's silly not to recognize that, okay? And that there's acute effects and there's chronic effects, and we got to look at this and try to come up with some. Everybody knows I use this term that came up with my business, middle path medicine, because I always was saying Western medicine says this, natural medicine says this, truth somewhere in the middle. Because I still was online about how marijuana is called 0 deaths in the history of humanity. And it's like, come on, I mean that's not true, but it's a lot safer than almost anything else anybody can prescribe to you. But I don't know anything in the world risk-free, so therefore, marijuana must not be risk-free because it's in this world. That was easy. Anyways, lifetime dependence risk, and this is straightforward. 32% for nicotine, which is more addictive than heroin, by the way, which is more addictive than cocaine, 15% for alcohol, 9% for marijuana. A very important thing to understand has to do with the developing brain, which we've determined now that your brain doesn't fully develop till age 25. Okay, so it is considered vulnerable to addictions. All of them, But you can become addicted at older ages to these other substances, whereas it's next to impossible for some reason to get addicted to marijuana if you don't get addicted at a young age. Okay? So I want you to understand that. Any addiction, this 9% addiction rate, if you think it's the #1 illicit drug in the world, and actually I didn't put that in there, worldwide it's the #1 illicit drug. Okay? Now, obviously, alcohol is more common and caffeine is more common, but in terms of illicit drugs. So if you take 9% times the world's population, it's an enormous amount of people who have an addiction to this. Do you understand? It's a very important problem that can be out there. And so it happens because of use at younger ages. Now, this number here, more than 50 exposures before the age of 18, okay, and this was a Swedish study there was a European study, excuse me. I think it was 240,000 people followed for 27 years, and a lifetime risk 7 times the rate of schizophrenia as those never exposed. Now that sounds horrible, oh my gosh. Well, schizophrenia has such a low rate in the population, we're talking about a very small number, but it exists, okay? Now, and most people understanding that, and again, what I would tell you is that really after age 18, the safety profile of marijuana becomes much safer. I don't think anybody out there in the world is really trying to get adolescents on marijuana. I don't, you know, and so I really want to be clear about that. I agree with choice, et cetera, et cetera. We need to work with our children, talk about regular use of alcohols and other things, and you know. But really, is anybody really actively promoting daily use of marijuana for a 15-year-old? I mean, come on. I don't think so. And it's not medical marijuana most of the times. Now, don't get me wrong, it can be used in the cases of glioblastomas and other things in kids and leukemias. I mean, that's a medical use for it, but please be clear, we have to be careful about the general population. Yes?
In regards to the schizophrenia, some of the studies that I've read are saying that these kids are beginning their signs of depression and not feeling like they're within themselves, and so they're looking for something to self-medicate with.
Correct.
Alcohol doesn't work, it's just like too wacky, and that's the medical marijuana, or the marijuana that they're trying, sometimes 50 times before they is doing a self-medicating event. So is it causing, or is it something that they're using to treat, and it's just coincidental?
This is a great question, and let's talk about. There's by the way, a 2000, and I didn't give a whole set of references because I have some websites that refer to these articles. There's a 2012 review in the Mayo Clinic Proceedings by a doctor that I'm blocking on his name. And he does a very good job as a psychiatrist reviewing some of this literature as of 2012 anyways. And the purpose of the question, which is really spot on, is the literature is confusing. Does the marijuana use cause and or is a sign of someone self-medicating? Does it lead to a more, and this is what the psychiatrist's conclusion is, it's not causing it, it's exacerbating it. These kids are self-medicating, it leads to more of the negative symptoms of schizophrenia. You know, everybody talks about the classic view of the stoner sitting there and like this, like that. Those are called negative symptoms of schizophrenia. And you have a higher rate of negative symptoms of schizophrenia in the schizophrenics who use marijuana. Okay, so you're probably exacerbating an underlying predisposition, okay, with marijuana. There is some evidence, however, that it may induce it as well. Okay, it's such an uncommon condition. Like I said, 7 times the rate of schizophrenia sounds horrific, but it's still a very small number of people exposed. And it still goes down to its exposure before the age of 18. Okay, and it's regular use. And the definition they use is 50 exposures, okay, as being high use. Okay, and so it's very important to understand that, and especially if you have a predisposition towards this psychotic effect. You know, anybody's experienced how eating, you know, in college I ate a whole thing of, you know, hash brownies, okay? And, you know, if you can eat the whole thing, you know, it's like it had quite an effect over a course of time, okay? And because you could eat a lot, it's like, damn, these things aren't doing anything. And I was a typical, whatever, 17, 18-year-old, and it's like, damn, oh, this is great. I ended up eating a whole pizza after that, by the way, the most huge pizza in the world. Everybody was very impressed because very few people could. My brother, I used to tease him, he could only eat like one piece of this pizza, and I ate the whole damn thing after this plate of brownies. One of my prouder moments, obviously. Anyways, but what people often call the side effects of it, yeah, that feeling of expansiveness and everything that you get with marijuana, I think are pretty cool. Who knows if you use today's, now remember that was 1980-ish marijuana, and if it was much more potent and I had done the same thing, could have I had more than just that expansive, wonderful feeling? Very possibly, okay? Because you can get much higher levels in because you can get so much more in when you don't self-regulate by smoking it like you usually do, okay? And so on that order, when we're seeing the stuff with, we'll get into the gateway drugs and things like this, with the use in Colorado, if people do heavy exposure, especially orally, where they can overload themselves, they can have psychotic episodes with using marijuana, which makes sense, by the way, okay? Is that something they're predisposed to anyways, or is it because of the more potent and psychoactive effects and naive users, like I was in college and things, using doses that were excessive? Again, I think all those things have been going on since the beginning of time. So yes, I think everybody knows I've inhaled before and everything else. It's all okay. But I don't use marijuana that much. I just don't. I mean, I have other drugs of choice, but clearly I have nothing against it. I mean, so again. Well, it goes down to here. Cannabis is associated with a higher risk of drug experimentation. All right, let's face it, okay? Be clear. The studies show it is not a gateway drug. Everybody who continues to say that, the research does not support that one iota. As anything, it does show, which I think is a concerning, what they call the reverse gateway drug effect, is that marijuana users have a higher rate of becoming nicotine dependent than never marijuana users, okay? Is that important? Yes. Okay, but not for the reason that people think it's going to lead you to more drugs. It's especially the old-time literature. It's marijuana use is a sign of deviant behavior, which means you'll experiment with drugs. And if you want to call that deviant, then sign me up. So it's drug experimentation, which has been going on in human culture since the beginning of time. Same thing goes when we use this term psychosis. We are the only culture when you see a vision that only looks at that as being a negative thing. Okay. Now, if that vision is associated with you don't feel good during it, okay, that is obviously not a good thing. But not all visions, that's why spiritual use of cannabis and mushrooms, etc., have been around for a long, long time. It's another thing to embrace about our history. But the use of, under your shaman or whomever else like that and taking vision quests, etc., is extraordinarily useful as part of your life. I wouldn't want people not to experience some of those things unless they didn't want to, okay? But making it illegal, And so, but that whole thing about deviant behavior, yes, there is an association between people who smoke cannabis having a higher rate of experimenting with other drugs, but not becoming addicted to them. That is an important distinction, I hope you understand, right? Cannabis pharmacology. There's not enough about cannabis pharmacology, and I was going back and forth and trying to get an understanding of what the differences are. I mean, obviously, I've experienced the differences, and be clear, the rate of bioavailability among people is extraordinarily variable. So when we say ingested by mouth, bioavailability, they're primarily talking about THC in most of the studies. CBD, I think, was in a few percent of the trials. They really focus on THC because it's the best understood of the cannabinoids. So ingested by mouth, bioavailability is definitely lower, 6 to 20% of the bioavailability, meaning one person might absorb 3 times as much as the other person. I hope you understand that's what that means, okay? So variable bioavailability, peak concentrations of THC occur 1 to 6 hours. I would guess with me about 2. If you do orally. So that's the thing, is you can expose yourself to a lot if you aren't feeling it, okay? And that to me is the main concern with naive users of cannabis. And that's a very important distinction we have to get to. Even when we look at the driving effects, naive users shouldn't be using, okay? But because that can cause problems. But like in the other trials, if you're a naive user, you can really become intoxicated, okay? And then going out driving is a really bad idea, okay? However, chronic use, because it can decrease anxiety and other things, they've actually shown that chronic users can perform better on driving using marijuana. Okay. Now this is where it gets complicated because people want a black-white world where it's wrong to drink on marijuana, to drive on marijuana. I know people that I wouldn't want driving without marijuana, and so it's true. You see them on the road. You know what I'm talking about. And so on that order, acutely ingesting going out for the first time? No. Okay. Difference between oral ingestion is it goes through what's called first pass metabolism. Whenever we take things in through our mouth, okay, and into our stomach, it goes through first pass metabolism through the liver. Okay. This is true for all medicines, of course. This 11-hydroxy-THC is a more potent psychoactive metabolite than you get by inhaling. And that's another concern with ingestion is that you get potent metabolites of THC that you don't get through inhalation. And this version, 11-hydroxy-THC, is not associated with the therapeutic effects of THC. It has some of them, excuse me, but it has more toxicity and more psychoactive effects, so it's not something you're trying to increase. And this is why oral ingestion is another thing where we're saying, gosh, is this the best way to do things? For some people, they just, either whether you use a vaporizer or whatever else, they just don't want to inhale things. Be very clear, inhaled cannabinoids are much easier to regulate because you get peak effects within 2 to 10 minutes and a much more rapid half-life and less generation of the 11-hydroxy metabolite. It is easier, anybody does this, knows it's easier to regulate inhaled cannabinoids in terms of if you're looking for psychoactive effects than it is to regulate oral cannabinoids, okay? Because of these pharmacological differences. As well, and this goes into especially with the research that I've looked at high CBD fractions of marijuana and done by vaporizer has shown profound anti-inflammatory effects in the lung, improvements in asthma, okay, and it can be used to treat lung inflammation unlike cigarette smoke. So once again, I want to be clear, there's a unique difference between these compounds, the cannabinoids, their effect within the lungs, okay? So this has a very potent, good effect on the lungs, okay, as compared to cigarette smoke. Much different. And people have mistakenly, there is no long-term association between marijuana smoking and lung cancer. It goes on and on and on in terms of there's no linkage between the chronic usage of marijuana and cancer, okay? Probably because it has some anti-cancer effects. Yes?
I was just asking is that like using vapor, or because, you have people using whatever they can, papers or whatever to use the marijuana.
The question to go... This goes into what is the best way to do marijuana, and to be quite clear, and this is where I was going to get to the things, there's people better at this part of the talk than I am, okay? Yeah. No, no, absolutely. I mean,
the main difference is when you use vaporizer, you're not burning all the medicine. Okay, when you roll it up in a joint or you roll it up in your bong, you actually burn, you suck in carcinogenics from the lighter. You get contaminants from the paper that make it burn faster. When you use a vaporizer, heat basically ignites THC. Those are your vaporizer deal, so you're just getting the medicinal part of it. So the stuff that inflames us would be the butane, the tar.
Correct.
If you ever looked at a guy's bong, it's nasty. Well, that's what your lungs look like. They say it cleans 99%. Myself, I use a volcano, a vaporizer.
Right.
And sometimes my nursing staff don't understand the difference between volcanoes and smoke.
Right.
Because it's not smoke.
I've seen vaporizer, I guess they might be older vaporizers that did ignite them. So the newer ones that don't, they just heat.
It's just heat.
Okay.
And you actually have a byproduct that's good for baking.
Right.
If you want to get the CBD out of it. So.
Yes. Baking. Okay.
Because we don't use it all. We're just basically burning the THC off the leaves.
Right.
Or off the, what do you want to call it? The callus, the THC off the material.
Right. So.
In a nutshell, the vaporizer is the best.
To get to a conclusion on this, where we're trying to get to people is using whole plant, first of all, okay, versus just, and I'll be right there. Okay.
If you're vaping, you're not using the whole plant. You're missing out on a great deal of plant versus if you are smoking it in a water pipe, if you put ice in the water pipe, you've cooled the smoke down, and so you've reduced the risk of getting any problems in your lungs, COPD, because you've cooled that smoke down. It's that heated smoke that burns everything as you're going down your throat, your lungs. So it just depends on, do you want to use a whole plant and get all the benefit from the plant? Or are you just trying to use a selective piece from
Okay.
it and not give your body what it may need?
Yeah, and so getting it, so this is the controversy where we're at right now. There actually isn't a defined best way to do this because there hasn't been enough research looking at what is bioequivalent dosing. We already talked about with orals or the sprays and things, there's a variability of absorption, but it's not a wrong way to use it because trust me, we use a lot of things that have horrible oral absorption, but they can get in anyways. And so you just have to say, that's a little bit more difficult, and we get a toxic metabolite through oral ingestion. Okay, that might be a problem. Okay, but going back to this, the smoke itself is actually, if cooled down, very well tolerated and gives you more of the active constituents than even you do with a vaporizer. But the vaporizer is easier for most people to use and more acceptable, especially going back to the old pothead things. If somebody was comfortable smoking and doing a water pipe in the past, it's not a big deal to prescribe this. Whereas for most of our patients who, I don't know about this, most of the research is done on the volcano vaporizer that he's bringing up. That's where most of the research has been done, not all of it, but most of it. So that the vaporizer, at least to have some standardized studies using that vaporizer. Yes, sorry.
I was a 20-year, 2-pack-a-day smoker, okay? I smoked cigarettes. And I was still using my bong, and it pissed me off because I had all the side effects of still smoking. And so, a vaporizer was $600. And I told my wife, hey, I'm at it. Why quit smoking? I still can't breathe. I've got all these problems. As soon as I went to the volcano, guess what? You don't hear gurgle. She just wake up, I'm not breathing. So, I actually quit smoking cigarettes because I thought I was drowning at night and was almost ready to quit smoking medical marijuana because it gave me the same side effects as the cigarettes.
Right.
Again, it helps me psychoactively and also with my cancer. So, I
Correct.
found an alternative. Just a deal eating and smoking.
Right. And so actually you could make a thing that you could use orals from, and now especially this gets into what am I using it for, okay? So if you're treating chronic pain, okay, let's just use that. Many of our cancer patients are in pain, obviously, and that's an important thing to treat, but we talked about neuropathic pain, fibromyalgia. There's studies in rheumatoid arthritis and other forms of arthritis. So let's say we're treating pain and use a pharmacological model where you would use an ingestion, okay, and whether that's a tincture or a brownie or a ginger snap or whatever else, a small dosage or something that you become experienced with, whether it's a sativa, indica, etc., that gives you a baseline pain relief, and you vaporize just for the effects of THC that you want for pain relief. See, that would be a good pharmacological model of treating chronic pain condition. Okay, so the right dosing, by the way, is going to be worked out based upon what you are treating, and how you respond to it. The hugest part of this, once again, is there's enormous variability in terms of half-life, in terms of bioavailability, and in terms of especially true orally. But that doesn't make it impossible to use. I hope I wasn't implying that. I'm just saying it's more difficult to regulate, and it's more easy to overdo it if you're being drug naive and just doing, oh, this isn't affecting me, this isn't affecting me. Like, slow down. Okay, it can take up to, say, a couple of hours for a peak effect from oral stuff. So just dosing it every 15 minutes for your pain, ooh, please don't do that. Okay, and when people talk about this, it can be synergistic with opioids. Okay, can you use opiates with this? Remember, the morphine literally means love of death. Okay, that's what the word means. Okay, from Latin. Chronic narcotic use is not compatible with human health. Period. Okay, chronic marijuana use is entirely compatible with human health. Okay, so I really want to be clear about that. You cannot use opiates chronically and expect to be healthy. The shutdown effects on the entire neuroendocrine system is not compatible with living well. So if you have chronic pain condition, it's much more intelligent to find a sativa during the day, an indica at night, whatever your balance is, some oral and some version of inhalation, especially if you're looking just for the pain relief. Burning off the THC with a vaporizer is probably your best bet. Okay. Now, when you're looking for therapeutic effects as well, then you have to go into, I wonder if it's better to use an inhaled through a water pipe bong, etc. Okay. And so the dosing is going to be based upon what you're treating. If you're just doing something and you want to prevent chemotherapy-related nausea and vomiting, again, the THC is going to be by far the most important thing for that. And that's a vaporizer is probably your smartest way because it's the easiest thing to regulate. And you can, again, just dose yourself as you need to, okay? And once again, if the primary side effect is, well, I just feel kind of good, that's, in the world of side effects, it's a lot better than all the nausea and vomiting drugs that we have. I mean, come on, take enough opiates and you can't crap. Oh, geez, that's a bit of a problem, and so, so this is a lot better than that stuff, okay? This is just one version of vapor pens as well too. Go YouTube video this stuff and go to that great medical journal, High Times, and they rate all the vaporizers for you. These people are a lot better at the practical side of how to get your prescription and how to use it, honestly, than I am. I actually need to get better at understanding how to do it. I really do. I know enough to be dangerous, as they say. But I do count on people looking, because this information is out there. This is one of the benefits of the internet. You can YouTube video pretty much how to use anything in this world, and it's not difficult to find. So if you don't know how to do this stuff, it's demystified. If guys that come on there that usually look like they smoke marijuana. Sorry. Hi, dude. This helped my chronic back pain, and this is how you use this vaporizer. And it kind of goes like that. It does. It really does. And so, and there's nothing wrong with that. I mean, but, it's the same thing goes as a doctor. I had a patient, and we prescribed medical cannabis, and she didn't want the person to come to her home, so would she come to my office? And it was one of those classic, the guy comes in straight out of some surf movie into my office, like, dude, you're Dr. Foresman. It's like, oh God. Yes, I am. Oh man, we've heard a lot of good things about you. It was like really just like that. And this is exactly why my patient is sitting there going, it's okay. He's a nice man. And he knows a lot more about this than I do. And he shows off all the different varieties of things and for her to try. And at the end, it was a good thing. She just didn't feel comfortable having somebody go to her home with stuff, which is understandable, of course. And so I said, sure, you can come to my office. I want to meet this guy anyways. Apparently, he wanted to meet me as well, so it worked out. And by the way, in terms of recommendations, we need better dispensaries. And we need them to be available to people, to educate them, to get the right prescriptions and things. The federal government continuing to raid our dispensaries in the states that are legal is just sickening to me. It is just, and I obviously that's one thing I have probably too much attachment to. It's immoral, it's unethical, but we continue to have the federal government raiding dispensaries in states where it's legal. So I for a while felt like I was the kiss of death of dispensaries. As soon as I was using a dispensary, bam, it would be closed down. And no, seriously, it was it was all my marijuana use. I was beginning to get paranoid. Just kidding, that was a joke. So it's, I want to find, there are some good dispensaries I've been to in San Francisco, but there aren't any, and that's many, many years ago. And so on that order, I don't know if they're still around. So we're trying to find good dispensaries. For the most part, you have to develop relationships. I found a relationship with a local grower, and then she stopped growing. It's again, when it comes to the practical use of marijuana, honestly, there are people better than me, and you say, well, why are we doing this talk like this? To have an understanding of how this stuff works and to open up this conversation in terms of how to demystify medical marijuana, to get people to be, and this is really, to be experiential. Okay, and it's nothing. When you try something like this, if you have a side effect, you don't like it for whatever reason, it'll come and go. Okay, and then say, "Gosh, that version of marijuana I don't like," and then I'll try another one. Okay, and I can try another one. And whether you like higher levels in THC or higher levels of CBD, etc., you can tell based upon how you feel. I want to emphasize that. Now, when we get into the chemotherapeutic effects, and this goes into. There are so many, and this is important, in most models, with the exception of lung, CBD does outperform THC in most models involving tumor regulation. THC does have anti-tumor effects, and it's going to be a whole plant extract with some ratio of CBDs and THCs within them that is going to be the important effect. Okay? We still don't know if we were using medical marijuana intelligently, we would have research looking at various ways of modes of delivery, okay, different ratios of and total milligram quantities of CBD and THC. You would be measuring levels within the person, and you would be looking in vivo at what kind of tumor effect you got. And now when I say in vivo, that means in real life, okay? Of course, you would start with some animal models to look at what happens when you do this typical studies, etc. So there are many, many effects. So especially in breast cancer, they did some they call them knockout mice, but where basically they take out systems, the endocannabinoid systems, and be clear, we don't know all the mechanisms of the anti-tumor effect, especially in breast cancer. Any known receptor for cannabinoids, it still has an anti-tumor effect, and we don't know how it's doing it, okay? So far, all studies indicate synergy with chemotherapy while protecting normal cells. This is a very, very important fact, which is that does use of medical marijuana during chemotherapy negatively affect the chemotherapy? No, and it's protective to normal tissues. Yes?
So when I go back to the doctor, the nurse, and they say, how do you know that?
Because it's been, most of this research is in cell lines. Good question. So the question is, how do we know this? Okay, because and again, within the trials using for chemotherapy and nausea and vomiting for all the patients that have been specifically looking at that, there's been no decrease in tumor responses to chemotherapy, etc. In the tissue models and things, when you have cannabinoids along with the chemotherapy, there's actually increased tumor killing effect and an improvement of the host tissue if it's done not just in a tissue cell line. So our basic understanding, this is really important, when you do clinical trials, it should be based upon these things. What's the effect on the tissues? What's the effect on these animal models that we're using? Okay, and when you see that, there's a consistent effect, which is that the CBDs and THCs and other forms of cannabinoids have anti-angiogenesis effects, they have growth inhibition effects, they have inhibition of metastases effects, so many things that we're looking for on cell lines when they're used in tumor models, especially, transplanting certain tumors, especially breast cancer, onto a mouse model. What happens when you use intraperitoneal and other versions of cannabinoids? Sorry about all the medical stuff, but this kind of goes into that you can see that you actually have beneficial effects in terms of mouse survival, etc. Okay, so now in terms of human trials, the human trials are primarily just looking at what it's indicated for, does it help chemotherapy-associated nausea, vomiting, and this is the marinols and things like that. The answer is mildly so, okay, but with no decrease in tumor effects in terms of anti-tumor effects of your chemotherapy. So there's actually a lot of evidence indicating synergy, absolutely no evidence to indicate a negative. That's how we know. Does that hopefully answer? Yes?
What's the main reason to use it for cancer?
The question is, what is the main reason to use it for cancer? Okay? And as a doctor who's using this more and more, but is still naive in how to use it, I want to be clear about that. My first issues have been in helping people with pain. Okay, so that was my first thing. A lot of people who have bony metastases, that was one of my main things, is that I want to use something that I know is safe for them because of these reasons. Okay, I don't want to give them opiates, and I'll go into a couple of reasons. I don't want to give opiates, love of death, because I know opiates are a short-term solution leading to a long-term very bad outcome. Okay. Furthermore, most of you know in my cancer treatments, one of the things I use is an opiate antagonist known as naltrexone, and you can't be on opiates if you use that. So I want to have people on naltrexone, and they can't be on opiates while they're on naltrexone. And so that's one of many, many things I have my cancer patients on is this opiate antagonist known as naltrexone. And of course, unfortunately, if there's bony metastases especially, there's a lot of pain or local tumor effects and other things. So my inroads into using cannabis was solely for pain treatment. I want to say that's how it was my gateway drug. But the beauty of it is I wanted something that I knew that at least had trials showing that it was safe to use with that. I wouldn't have negative effects if they're on certain forms of chemotherapy, et cetera, and was more efficacious than all the drugs we were using, the Zofrans and the Phenergans and things for nausea, all the opiates for using it for, and obviously nausea, another reason to be using the opiates. So I have a much safer version of a medicine to treat my patients while I'm treating with all the things I do know how to use very well. And I do know how to use a lot of things with cancer. How to use it therapeutically within cancer, like this gentleman. Do you mind telling your story about what you did in terms of your treatment?
What I did in my treatment was the first month of my chemotherapy, I thought RS oil was getting high. And I was really scared because I have 2 ball-sized tumors in each side of the lobe of my liver and one so big in my colon that the scope couldn't pass through. So as I did research, you don't find a lot, but you find some in Europe. And they say that the high THC turns off the cancer cell. And so I said to myself, well, I also own a medical marijuana collection. And so I said, well, with all this access to what I have, I need to do this. And I started off eating 10 grams in the morning and half a gram at night. And within 2 weeks of me starting this program, my blood work started to get better. I called my doctor and their staff, and they kind of, but as far as I'm concerned, I was ignorant to it for the first month. And then the second month, I smoked it, don't get me wrong, but when I read that and did more and more research, it's my life on line, I said, I'm doing this. And to make RSO oil is illegal in California.
So what are you saying, making what?
Rick Simpson oil is a process used where we use alcohol-based products to extract THC from your cannabis.
Right, okay.
Versus a butane, which when you go to collect it, you buy honey oil or wax or pH oil, that's all made with butane. Part of my problem was the residual effect of the butane on my body. How do I know how that's going to work? I didn't like it. So I used Everclear. Everclear, the residual effect on my body is alcohol.
I used that in college too, by the way. I'm sorry, go. Sorry.
And so you hear spreading the word, at least with my patients, that it works for me. Everybody's different, as he says.
Right.
But you know what? And now let's get to the cycle part. Part of having cancer, I feel like I want to cry right now because, someone stamped an expiration date on my forehead, and I didn't know how to deal with that. Through smoking marijuana, I can deal with it. And it's always difficult when you find out that, you may not make it to 70 or whatever the hell I was saying. And so one of the things on the positive side is we're all guaranteed to die. How many of us are going to choose to live today?
Right.
And that's what came to me, at least. I could be bitter or I could be better. And I choose to be better, and I choose to live today. And if I have to take marijuana products, so be it. If people want to judge me, so be it. I'm alive and I'm living. And so as far as that goes, it's touched me in a positive way.
Right.
Even though it's scary as hell, I went on the 25th to have surgery with taking out the foot of my colon, my appendix, and fondling my liver, as they call it. And when that surgeon, you read, non-invasive, when she drew this and said she's going into the liver guy's thing, I about fell out of my chair. I asked my wife, I didn't ask any questions. That's another thing, you better bring a friend, because when you have cancer, I don't care what, it's very hard to deal with.
Right.
Every day is a new day. Some days I'm mad, some days I'm happy, some days I don't know how I feel.
Yeah.
But I do know that through the use of medical marijuana that I'm able to get myself in a place where, I grow specific strains that make you happy, so I deal with depression. And so, therefore, it does pull me out of my fun.
Okay, so thank you so much. Okay. And I hope everybody gets a little, and still something out of that from a standpoint too, the healing process. I was talking with somebody earlier. My main interest in cancer is as the cellular expression of the loss of sense of self. Okay, so why am I interested in cancer? Because in my history as a meditations instructor, as a physician, and knowing so many other systems of healing, what I see in this world is the primary disease that we're facing is a loss of sense of self. Okay, and what that means is you are always there, but most people don't know who they are. Okay, and something like a cancer can be a journey to saying, wow, it's about time I figure that out. Okay, and so many things are distracting ourselves in our life. Okay, and I alluded to the fact that this approach of trying to bomb the world, bomb terrorists, bomb cancer, is a sign of how deluded we've become in our approach to the humanity of healing. Okay, and how fear-based, most of the things we do, okay? It's not just cancer treatment, but it's a lot of things. The doctor, I have patients, if you don't take this statin, you're going to die. I mean, the doctor will try to scare the patients, and this is heart disease, a drug, and that's not an accurate statement, by the way. But I've had many doctors tell their patients that we try to scare you into, it's a form of manipulation, right? Using fear to manipulate our patients. Cancer, you see that especially. And in the biggest picture, why am I really interested in the treatment of cancer? Because it is the unique cellular expression of the loss of sense of self. Okay? And the only way to heal the loss of sense of self is to know who you are, and to help your body with the regeneration of, and again, and that's why I focus so much on programmed cell death mechanisms and other things, which marijuana is especially helpful for, okay? In terms of have signals to your cells that, hey, I'm supposed to die now, and those cells will die. And getting cellular redifferentiation, where a cell which has lost its way will turn back to being normal. And nutrients do that, not drugs, okay? You cannot poison yourself to long-term health, period, okay? Okay? And so back to this use of cannabinoids and whole plant extracts, it's an experiential process. I don't know if you might have got as much benefit from having the loss of sense of fear and some other things in your healing process as much as it was the THC. I'm sorry, that's what hit me when you were talking. And I'm not saying it wasn't the THC, because that's not, okay, because we don't know. Anecdotally, though, this has given him a sense of calmness and ability to deal with things, okay? And that's something that's, medicine, especially oncology, can be quite inhumane, because we are bombing you. Okay, and there is a time and a place for that bombing and the surgeries and things. By the way, I'm not saying not to never. Integrative medicine means using everything, including Western medicine. Anybody who's my patient knows that, if I can get something cut out of you, and I know that's things, I will. And then that will decrease our tumor burden. It may increase the ability for your immune system to recognize what else is left there, so your body can do the rest of its job. Okay, there is a time for careful extractions of things, etc., and chemotherapies. But also this whole part of the healing is that you can activate systems in your body that help. Okay, when I was talking about spirit quests and journeys and things like that, drugs can give you, it's basically states versus stages. Most of you know that I'm a very Ken Wilber kind of guy in terms of looking at our body and how we look at things integratively in all kinds of levels, not just medicine. But it can give you state experiences, drugs, where you have a glimpse. This is what it feels like to be human, okay? Really. You look at the joy of a dog, and they don't know better than not to run around and jump up on people and things like that. They don't have a prefrontal cortex telling them that's socially inappropriate. I still jump up on people all the time, so again... It's still socially inappropriate, but I do it anyways. So in terms of using these medicines, okay, is that it can give us that part of things where you never know what's going to trigger that person to heal. Okay? And it can be chemotherapy, by the way. If you believe enough in that stuff, it can be. And it can be surgery, and it can be medical marijuana. This is why you have to make the choice of saying, I'm interested in this. This is the thing is, we've got to get it away from being demonized. This is a wonderful herbal compendium of effects. And why wouldn't I expose myself and see how I metabolize, etc.? I would like, as a doctor, to know the pharmacogenomics better and look at the different mutations and who might not benefit. We're doing that with other drugs, and I know it's going to happen with marijuana if we'll look at it. Sorry. And that the benefit partly, I think, in the healing is bringing the human aspect back to healing. It's not just about the bombing. Yes, you had a question? Ron? No? Didn't you? Oh, sorry. Okay. And so there is profound anti-tumor effects. Okay. These. He wants a card.
Unfortunately, my clinic is private, and I've made a conscious decision to deal with my own battle with cancer before I can go out and help people, because it's just too hard.
That's very.
Show me your house and cry.
But I do want you to hear that process. Even though we're focusing on CBDs and THCs and CBNs and CBGs and all these other things, the component where you take away the fear, okay, because fear is a driving force in cancer. Okay, there's a lot of studies on the effects of adrenaline, especially with pancreatic cancer, by the way. They have great studies on adrenaline being a driving force and making the tumor more angry. Okay, so fear is something to be recognized, and I say overcome, from a standpoint that everybody has a different way. Medicinals like this can give you that glimpse, that state of awareness, that's more likely to have you work on that becoming a stage of awareness. Okay, you can't drug yourself entirely to that stage. That's not going to happen. And that's part of the reason why I think so many, especially people with issues towards schizophrenic problems, probably try to drug themselves to that state. Okay, and that's becomes part of the problem, because now the chronic daily usage is a different thing. The effects, by the way, of cannabinoids, when you start using them day in, day out, day in, day out, they do change. So that's another thing to be aware of. Okay, so yes.
I understand cancer is a trigger word. Both of my parents died of various cancers, so be it. What about just in general life and longevity? Is there a path where this is beneficial?
The question goes into, looking at life longevity. Is there a role for cannabis and cannabinoids? And the answer is possibly, because, it was like when it goes to alcohol, I can't remember which president said, it's not about the misuse of a bad thing, okay? It's not about the use of a bad thing, alcohol. It's about the misuse of a very good thing, okay? And that's a good understanding of alcohol, okay? And I promise I'm answering your question, but trying to do it in a global way, which I know if I'm talking too long, I apologize. And so, so to answer that question effectively, feeling good is a good thing, okay? And it's somewhat demonized in our society as being a bad thing, okay? Now, it can become its own disease, okay? Just trying to feel good at all expense of everything else, okay? But feeling good is a good thing. So when you look at the long-term trials in terms of the cohorts, alcohol is one of those things associated with longer life, unless you die from a motor vehicle accident because of drunk driving, okay? But the chronic usage of it is a healthy thing. Can it be misused? Yes. Okay. So going into the effects of cannabis, if you look at all the things that it can do, from anti-inflammatory, etc., could it play a role in preventing new onsets of tumors in people who don't have them, and people who are genetically predisposed? It could have that role, very much so. It's not proven yet. Okay. There are no studies on the long-term use of cannabis that shows a prevention of cancer, though. Okay, just to use that as an example. Okay, and so, and because most of the studies looked at, they were thinking it was going to increase the rate, but there was no decrease either. Okay, so is there any improvement in quality of life? The key is, like the 9% are using chronic daily users. That's an addiction. That's a problem. What about the other 91%, the other people who use this without becoming addicted, that other 90+%? Can it have medicinal effects? Yes. My experience foundationally for health, of course, is whole food nutrition, stress management, of course, some form of self-realization practice. Because really what it comes down to is we need people kind of experiencing the self again. Okay? The real cool stuff about cancer these days, it's just a continuation. The genomic instability that occurs with cancer is an epiphenomenon. Sorry, the doctor speak. All right. It's tough to translate this stuff into real terms. So, genomic instability just means we all know with cancer that there's genetic mutations that do occur that lead to escape from growth factor inhibition and blah, blah, blah. Okay, so what we're talking about is that the genetic mutations occur as an adaptation to stress, inflammation, and glycation. The three primary driving factors in cancer are excess blood sugar. So is your hemoglobin A1C under 5.2? If you're not, you are at high risk of developing cancer. Okay? So metabolic glycation is a form of aging, okay, is very, very significant problem. The high carbohydrate diet in our society, etc. Okay? The next part of things, inflammation. So many things are pro-inflammatory in our society, processed foods, etc., etc. Keeping inflammation. Is your CRP less than 1? There's so many other markers you could use. But if you have any elevation of inflammation in your body, you can need to treat it. And one of the things that can be used, finally getting to the answer, is CBD and other extracts because it has a higher anti-inflammatory effect. And if I was using something chronically and I wasn't getting there with my curcumins, my diets, and my everything else like that, I would bring down inflammation long before I ever saw any evidence of cancer because that's a driver of the genomic instability which leads to cancers. If you look at the Society of Integrative Oncology, they focus so much on personalized medicine being looking at your genome and what all of screwy things going on in the cancer. Man, that's not going to be a very effective way of approaching cancer. Isolating certain drugs, sure, certain parts of it, but in terms of really healing the person, okay, it's going to be about them finding out who they really are. Can we use medicinal herbs to help us with that path in terms of settling us a little bit? Yes. Can it be the entire part of the path? No. Long-winded answer, I'm sorry, but yes, the driving force behind, and that's why we want anybody who has cancer or heart disease or whatever else. I'm a big fan of neutral self-inquiry. What was that all about? Sorry, that's neutral self-inquiry, okay? More or less. And the idea is to do it without the judgment of yourself or others as being bad. I'm a bad person for smoking. Well, no. I was telling a friend how I just have a patient who, survived a breast cancer, then an esophageal cancer, and she's just come out of a heart attack, and she finally gave up smoking. Woo! It's like, third time's a charm, but at some point you got to say, there was things going on. Actually, the time before she had her heart attack, she had an office like 2 days before with me, and she didn't have any documented heart disease, and she wouldn't get the test I told her to get to look for it. Sorry, but she wouldn't quit smoking either, and now she has. Okay, now I'm glad she survived all these things because she's got good German stock, and she seems like she can take anything. Okay, but at some point, she's got to think, wow, there's something going on metabolically. Okay, and so I hope she's gotten that. It's more than smoking, by the way. Okay, and so we do drugs for a reason. That's why you can't just say no to them. Okay, and so when it comes to this, can you be a conscious? It's like anything else in your life. Am I a conscious user of anger, or does anger use me? Am I a conscious user of my marijuana, or does marijuana use me? And only you can answer that in a meditative state. Get settled, whatever you call your meditative practice, just something, breath, and bring yourself down, and then come from that position. Is this marijuana something that could be good for me long term, or is it something that'll start using me instead of me using it? Because only you can answer that question. Yes?
In the end, literally smoking, lung cancer was one of them. What about the basics? Early on you said whole plant. Mm-hmm. Should we not all have a plant in our backyard and just eat the darn thing?
We should all have a plant in our
And that's why the pharmaceutical companies don't sue.
All right, so, okay, 3 minutes, okay. No, should we all have a plant? So many funny stories behind that, but all right, keep it down. Focus, Gary. There are ways you could use that. You'd have to become better using. There's a difference between using it raw versus heating in terms of what biological effects you get as well, too. And that's where we need to be better educated on how to use those things. Okay. Yes.
Okay. My friend here grows it. She's my grower. And what she has me doing now is I take the leaves every morning. I take about 20 leaves. They go into my green drink, which is honestly just a green drink. And then after that, sometime mid-morning, I take CBD, which is made up for me by using the grains with coconut oil. And it's like a fat I'm eating. And I eat something about the size of a lime.
No strain.
No strain. And then the whole about the size of a lime I eat. And then at night, she's made up the Rick Simpson oil for me, which I take in a capsule form up my butt because I can't take it in my mouth because I can't handle it. But I can take it up the butt. Is it helping me? I have no idea. She's still here?
Yeah.
Amen.
Of course, I'm also using Dr. Foresman's protocol and following his diet protocol.
I would just look at, and this is a key thing, is that, in this world, there's a basic saying, which is align yourself with those seeking the truth, avoid those who found it. Okay? If somebody tell you that this is the only answer, it's not the truth. I actually tell it within medicine. Whenever there's a medical consensus, at least I can go, whew, at least I know what not to do. Okay, so when there's a difference of opinion in terms of what to do, at least you know you're closer to the truth. Because really, once people say this is the way to do it, I know that's not the way to do it, and it's almost entirely true. Okay, now on that order, so things it needs to be this kind of conversation is exactly what we need, and to bring it out in the open and talk about this like without any kind of judgment of each other. Oh man, I can't believe he said he used marijuana. No, of course I did. And I use it every day, I'd tell you, but I don't. And I haven't used it in a long time, and I try it here and there, and it's not a biggie for me. Like I said, I have others.
So here, I thought the three driving factors, the third one somehow in this.
So the biggest thing, so it's inflammation, okay, which is CRP, and glycation, okay, and then just psychological stress, okay. So an actual program, okay, would be stress management and things that bring down glycation. And this is an anti-aging program, really. Anti-aging medicine. If you want to look at two anti-aging hormones, vitamin D, okay, loss of vitamin D with age is a huge factor in all solid tumor formation. Get vitamin D levels in the 70 to 90 range. The amount of vitamin D you should take is the amount you need to get a level to 70 to 90. Okay? And if that's 2,000 or 22,000, then that's what you do. So the right amount of vitamin D, which is a steroid hormone, not a vitamin. And you could look at melatonin. The loss of melatonin with age is probably even stronger associated with solid tumor formation. Melatonin itself is actually one of the most powerful chemotherapeutic adjunctive therapies that have ever been existed. Solid tumor trials using melatonin 20 milligrams a night increase survival from these solid tumors by 50%. Okay, so so looking at melatonin, can it be used preventatively after the age of 50? This goes into, remember we were talking about this endocannabinoid receptors? How many people here know that there's melatonin type 1 and 2 receptors throughout their entire body? Okay, melatonin is really about cell cycle regeneration, and the sleep effect is this tiny little part of what melatonin does in a human body, tiny. Okay, and I'm sorry if but there's so many things we can do to be healthy, and I'm sorry I'm off, but this goes into the treatment of cancer, which is my special issue. Please, for anybody out there who's looking at medical marijuana for the use of autoimmune disease, using it in inflammatory bowel disease, there's many other uses that research out there supports its use for as an anti-inflammatory, okay, especially. There's a lot of inflammation conditions out there. This talks about the pain relief. You saw that. Treatment conclusions. And again, I already told you, I'm disempowered, confused, generally lacking in knowledge. That's why I give the talk. I'm just kidding. There's many ways to use it, and it can be used topically for skin conditions and to get it oral. And it can be used by enemas. There's so many different ways to be using it. I just brought this up because, man, I didn't know people got this into all the things like, you know how people do that wine tasting like on Sideways, and this is like have all these flavors? I just saw this thing, and please, I apologize, I did not go to this website. Please don't go to it because I wanted to check and make sure it was okay. I just saw this slide, and I said, I've got to show this to you guys because I don't know if there's people out there maybe that just look at, wow, this is more of an herbal taste, and I prefer the tropically ones and whatever else. I just thought that was so cool. But. Are there pot snobs? See, and see that's, and I go, wow, this is awesome. This is just like Sideways.
Start off with it doesn't matter.
Okay.
And then about 3 months into it, they're like, you got to think better.
Yeah. I like the one there's like skunky over here or something like that. It's like, anyways, sorry. Helpful websites. These are just a couple. And I was going to do more and more. And I just said, listen, there's great links on both of these things. And I'm not saying there aren't other good websites, by the way. I really am not. Okay. But these are good ones. Okay. And I like Ethnobotanica because in terms of websites that I've seen and this is the Pot Deli, they really do a good job of breaking things down for people. And I just like this picture, and that's what I was going to end it on. Everybody knows I did the Blissful Dragon, and this was a dragon with marijuana. This should have been on my wall. Anyhow, so other questions? Yes. Okay. Well, actually, you had your. So hold on, just Joey. I apologize.
You mentioned some Bible references.
It's asking about Bible references. There's anointing oils have been understood to have hemp product as part of it for a long, long time, going way back before the time of Jesus Christ. And so the time has been expected that the anointing oils that were used, biblically speaking, definitely had hemp as part of them. which is fascinating.
Is your work insurance reimbursable?
Is my work insurance reimbursable? In my practice, I see patients, they pay me, I give them a Super Bowl, and the agreement between them is between them and their insurance company. So I need to be paid a certain amount for my services, like most of you probably feel like to, and if your insurance company won't pay me that amount, I can't have a business. Okay? So I'll be clear. Yes, it's reimbursable. The insurance rates are variable, and people have to go through everything I used to have to go through in terms of their insurance company deny them and this and that. I don't have the staff or the time to pay people to do that. Okay, so yes, my as an MD and using a super bill, I am not reimbursable through Medicare. Okay, but other insurances I am.
How about your supplements?
The question goes into supplements. Supplements, some people are writing off on their taxes and they're getting forms for their HSAs and things like that, but supplements aren't covered under people's insurances, as far as I know. And I think I had one patient actually who, if they could get certain herbs and things and CoQ10 through a compounding pharmacy, their insurance would cover it. Okay.
Change that though. Our compounding is not reimbursable by our insurance.
Oh.
I've been getting reimbursed for the megadose vitamin C through my insurance company. But
Right.
I'm having to go into Medicare, so I don't know about that yet.
Right. So sometimes the high-dose IV vitamin C and other things that we do can be reimbursed as well too under people's insurances. And so, so yes, on occasion. Yes.
As a nurse, we have to pay attention to, other drugs, herbs, teas. There's they take, blood pressure, thyroid. They can't take with these herbal things that they are saying, they're organic, but still, we need to educate them on being aware that they shouldn't be sometimes taken together. Is there anything definitely that should not be taken or being aware of with this?
So the question goes back to the cannabinoids have a lot of effects on, it's called the cytochrome P450 system, which is the drug metabolism system, from inhibition to being a stimulant to, meaning increasing metabolism. So there's a lot of research that needs to be done in that very area, and we don't know any specific drugs that cannot be used together with this, but my guess is there are. Okay. For right now, for the chemotherapeutic drugs, there aren't any contraindications. And it can be used with opioids. There's a few drugs it's been studied with, but right now most of the interactions are theoretical. But most people are saying stay away from the drugs like ketoconazoles and the erythromycins and things like that when you're on higher levels of CBD, because it can affect the metabolism of those drugs. So it's a good question, and yeah, and remember, everything can have an effect in the human body. The idea that these things are going to be devoid of drug side effects, come on. I mean, they're going to have some side effects. They're going to have some interactions. The problem is getting good websites and to go over. In general, if you look at Western, the websites, and I'm including Natural Database, and that's the primary one I'm using now, and I'm blocking on the other one that I don't use anymore. What's that? Not PubMed is another database looking at drugs. They use theoretical drug-herb interactions and not based on science. So, a classic one would be like vitamin C. Vitamin C still in textbooks says that vitamin C causes kidney stones. Actually, the only 2 double-blind randomized controlled trials on vitamin C shows it prevents kidney stones. Now, is that part of any database? No, it's still out there that it causes kidney stones. So it really is. And if you look at databases, it could cause kidney stones, and that's not true. Now, but everybody thinks it is, so therefore it is, in perception, I'm sorry, not reality. And so we're left with a lot of very, very inadequate databases that are based on hypothesis, not reality. And so it's a really difficult, especially the A4M organization is really trying to work hard with really good pharmacists and really good, a whole team of nutritionists to get an accurate database as best as possible. It's still tweaking it. So so on that point, everything on the internet is not true. Okay, so if you hear about it, if you hear about an interaction between a drug and an herb, talk to your doctor about it, please. Okay, and see if they are knowledgeable about those interactions. If they come from don't take supplements. Well, geez, that's pretty generic. Can you be a little more specific? Because we have to be careful now. Because most people, like you said, they're not understanding how many biological effects melatonin has. And it's like, well, gosh. I sleep fine. Why would I take melatonin? It's like, not why I'm doing it, you know. But they go home and it all goes away and they're just like, well, gosh, why are you taking that? You're sleeping fine. You know, and when we talk about the vitamin E's and the seleniums and the things that people are hearing negative things about, it's the type of selenium that's used. It's the type of vitamin E's are used. And we're using these generic terms like vitamin E. Which one of the tocopherols do you mean? And if your doctor doesn't know what the difference is, he or she shouldn't be answering the question, okay? But they usually don't. Or which version of selenium? Are you using methylselenocysteine? Oh, I didn't know about that. Oh, bummer. You know, and you have to get really, this is a complicated field. I'm lucky because my mind works in these ways, okay? And so putting it together is relatively, I can do. Most of the times, doctors are looking at a black-white world. Don't do supplements, you know. One of my favorite handouts of all time came from a radiation oncologist. And it was like, what to do during radiation therapy. Number one, eat. Eat anything you want. Here, you know, cereals, this and like that. Drugs. Take any drug you want. Supplements. No! And they're like, don't take any. You know, it's like, I don't know. I get such a kick out of that one. It doesn't matter what drug or horrible food you put into yourself, but if you take a supplement, you know, you're just going to. And the science goes completely against that. And that's why I was, you know, back to the reviews of integrative oncology. Every single trial, every single one done in a human so far using any form of antioxidant in combination with chemotherapy, every single one so far has showed a benefit or or neutral effect, okay? So why does every doctor say don't use antioxidants in my chemotherapy? Because there's a belief system that it doesn't, there's some horrible thing that occurs. And so lack of understanding that, for instance, the cannabidiol in normal cells in cancer cells especially has an anti-inflammatory effect, and normal cells will help promote decreases in inflammation. It's an immunomodulator. That's very difficult to doctors to understand because they're used to drugs going in one direction. Okay, so be careful when it comes to this stuff. It's so fascinating because it is so complicated. Okay, but when you hear, because I got from somebody I respect an email about all the horrors of cannabis when I was going to do this talk, and it was written in a medical journal, and it was so laced with inaccuracies. And this is an intelligent person, and they clearly took it seriously. And I wrote back very, clearly about how complicated this area was, how simplistic the chart that was sent to me was, and it's easy to be duped into believing, that cannabis is bad for you based upon some few bad trials. And so it's a wonderful question, but there is, of course, going to be some interactions. And I really want you to know that it's going to take a lot of people working together, a team effort, to try to figure out what the best way is to treat cancer, including medical cannabis. And be very, very clear, medical cannabis can be used for any pain condition, for any nausea condition, for any inflammatory condition. Okay, and it's something you should look into and have your doctor work with you on, because it's something that you should experience in terms of how you do. That's the way to do it. Other questions?
We have about 10 more minutes.
Okay, 10 more minutes. Yes?
Do you have another one of these lectures scheduled in this area?
Do we have another one of these lectures scheduled in this area? Get on Pam's mailing list and she'll let you know.
Yes.
You mentioned, or the slide mentioned cannabis and MS. What's the relationship there?
Cannabis has a large body of evidence of treating MS, especially the spasticity and the painful neuropathies that can come with it. So for whatever reason, it became one of the, especially in Europe, one of the primary conditions that medical marijuana was used in. And so there's a whole bunches of trials using Sativex especially, okay, and the treatment of the neuropathies and spasticity with significant benefits. Okay, so for that's one condition that medical cannabis has definitely been proven to be useful, including the plant extracts as well as even some of the other things like the dronabinol, the Marinol, and so has some benefits as well in terms of a pain relief standpoint, which is a good thing, because remember the things, getting out of pain is a good thing, okay, and it helps you on your process to healing, and if that's all it did, that is a darn good thing.
If there's no pain with peripheral neuropathy, does cannabis help restore some of the...
Good question. The question is, if you don't have pain with peripheral neuropathy, does it restore nerve function? And the answer is no. So will it help with numbness and tingling? No. Not in any trial that I've ever seen. The question, so does the medical marijuana, medical cannabis, does it help people who have neuropathies that are, for instance, numbness, tingling, etc.? And there hasn't been any evidence that they do.
It's more for pain.
It's helpful for pain. Yes.
They lowered what was making my neuropathy.
What's that?
My chemo, when I complained of that real bad, they lowered that drug that was doing that went away.
Yeah. Again, when you have chemo, right. When you have chemo-related neuropathies, one of the things you can do is change the dosage, of course. But one of the things that you also do, that one of the benefits of doing certain things like being on cannabis is you could use, most of the studies using antioxidants like glutathione for neuropathy, melatonin for neuropathy, show that you don't have to change. You can stay on higher doses of chemotherapy and get this, and hopefully get better therapeutic effects. So one of the benefits of combining therapy with because that's integrative medicine, is because people come to see me and say, oh gosh, it's chemo, or I do that natural stuff, and it's like, no. It's about this stuff playing together. We're trying to get the world to play well together, which is a difficult thing. But, okay, you can sometimes keep on the higher dosages by helping yourself and synergizing with the chemotherapy. Of course, one of the options is lowering the dosage. Yes?
It was in regards to, I think it was broken down in the liver, correct?
Correct.
So mainly, or do we need to worry and talk to our patients that have renal failure, that they should be a little more cautious with their dose?
Good question. And so actually most of the cannabinoids are broken down by fatty acid hydroxylases at the cellular level. That's the majority of the metabolism that's occurring, and some is occurring in the liver as well. But do you have to change dosage based upon impaired kidney function? No. With liver function, you do have to be careful about dosing because it will increase, slower metabolism will increase the amount that's present, and you'll have to decrease dosaging. So that's a good question, of course. Any others? Thank you.